So as we all know that in phacoemulsification, visualization of the structures is the most important thing. So small pupils become a challenging scenario for all of us. So this IC was designed to see how can we tackle this problem of small pupils. In today's IC, we have very eminent speakers and I'm very thankful for them for agreeing to be a part of this IC. The first talk will be by Dr. Phacoemulsification sir. He doesn't need an introduction. He'll be talking about small pupils with pseudo-exfoliation. Over to you, sir. No, sir. Dr. Nair, sir, please.
So since this is the first talk in this session, I thought I'll just have one slide on the different types of small pupils. We're going to discuss entirely about small pupils for 1 hour. I still remember maybe about 10-15 years back when you have discussed about small pupil, you will have one talk on small pupil and that is it. So now we have come to realize over the years that not all small pupils are not similar. There are different types that you need to encounter. So the first one is a routine senile myotic pupil. You see small white patches on the iris. The pupil doesn't dilate beyond about say 4.5 maximum 5 millimeter. But the patient is not on tamsulosin. There is no signs of IFIS. There is no signs of pseudoexfoliation. So that is a routine senile myotic pupil. You have IFIS where there is no telltale signs on the iris about anything, any of these myotic things. But you can anticipate it by the amount of pupillary dilatation, the duration of tamsulosin use, and sometimes the pupil dilates well and on the table you realize that this pupil is coming down and starting to flutter. The third type is pseudo-exfoliation, which I am going to sort of slightly expand on today, where the findings are different. And you also have the uveitic small pupil, where it is bound down by synic A, and because of that you have a small pupil. Now, pseudo-exfoliation cataract, other than the small or mid-dilated pupil, also has 3 or 4 additional things in it which you have to keep in mind when you operate. The first one obviously is zonule weakness. It does not necessarily mean that all pseudo-exfoliations do have a zonule weakness, but you should keep in mind that this is a progressive zonulopathy. Even if during surgery everything is fine, these eyes over a period of 5 years or 10 years can have zonule weakness and decentration of lenses, dislocation and things like that. It has been shown in various studies that there is a definite endotheliopathy associated with pseudoexfoliation, especially the ones where the pseudoexfoliation material is, you can see a lot of material on the surface of the iris. There is a lot of material along the pupillary margin. These eyes definitely do have a zonule endotheliopathy. Shallow AC is seen in quite a few numbers of pseudoexfoliation, and as I mentioned before, the laid back decentration that you can have. The iris in pseudoexfoliation, just few points about that. It's actually a dilator malfunction. The fragility of the iris, which I consider is a very important thing. Now you have a very fragile iris in uveitic eyes. So the moment you release the synic A and just use a Coughlin hook to separate the pupil, just they get a lot of sphincter tears here and there, and the pupil dilates immediately. It's a very fragile iris. While the IFIS iris is very thick, it looks a bit boggy. We can start off know which are the irises which can go into IFIS. In pseudoexfoliation, it is somewhere in between that. If it is a moderate pupil or slightly more than that, you can manage without any devices. It does not myose progressively, unlike it does in an IFIS. It does not suddenly come down. If it is mid-dilated, sort of it remains mid-dilated throughout the procedure. If by some chance you have a zonule dehiscence and you need to use an iris claw lens, you can get small tears in the iris while you are trying to enclave it because of the slight fragility of the pupils. So which device to use in case you need to use one? Any device which you are comfortable with, but capsule hook in eyes with significant zonulopathy, don't manipulate in the chamber too much by putting in a ring. And Malugin, or if it's a very shallow AC also, it's preferable to have iris hooks compared to either a Malugin or a BX rings. We have fans of Malugin ring in this audience. So I'll just briefly just show 3 cases of 3 different severities. Now, this was an eye where I did the rexis. There was a bit of zonule dehiscence, but after the rexis, I found that it was, the zonules were quite weak. I decided to go in with the capsule hooks. Now, once you use the capsule hooks here, the mid-dilated pupil can be slightly dilated, and then you can, once the hooks are in place, when you have that external tamponade or that hammock-like effect on the bag, then you can do all your procedures safely. Don't worry about whether I can hydrodissect or rotate. Usually it goes on very safely, and then the capsule tension ring is injected, and then you can go ahead with the IOL implantation. In this case, it was a single piece lens, and removing the capsule hook is slightly different from removing the iris hook because of the configuration of the tip of the hook. So you have to bend it slightly, and without causing any damage to the rexis margin, you have to remove the capsule. This is a second case where the pupil is small. I actually did not expect this much of zonule weakness, so I decided that I'll stay in the capsule and then go ahead with the Kuglen hooks and dilate the pupil and then go ahead. So that much I did, and after the dilatation with Kuglen hooks, this pupil sort of dilated pretty well. But once I started doing the rexis, I found out that the entire bag was moving around. So I decided that I will put capsule hooks, but you cannot get the full 4 number of hooks in this patient after finishing the rexis. So here you hook as you move. So you make a bit of rexis, put 1 hook, then again do a bit more of rexis, put the second hook, a bit more, put the third hook, and then do the 4th. So that way you can get a reasonably good capsular rexis, and at the same time you can have good support of your tamponade of your bag also. So once that was done, this capsule was secure, and I went ahead with a routine phacoemulsification. Phaco was not part of this talk, and so I did not show the video. But actually, this patient, towards the end, we had the entire bag being, caught in the phaco probe towards the last piece. I could not save this capsule bag, so this went in for a secondary implantation. Now, this is the third case. This is the last one that I am showing. This is a jet black cataract, very hard cataract, where I tried, expanding with Kuglen hooks. It didn't expand much, and the moment I started doing my rexis, I found out that the entire bag, large, huge nucleus, entire bag was moving. So I was not very keen on doing a phacoemulsification for this, because the specular count was also quite less, which is quite often seen in patients with pseudoexfoliation. So the moment I started doing the rexis, the entire bag was moving, and this was something, so I decided to convert. So here I did a temporal tunnel, and you can see very easily you can lift, because the zonules are very weak. Just with 2 hooks, just like you take out a rexis, take it out during an SICS, this entire nucleus came out, did a limited anterior vitrectomy, did an inferior temporal iridotomy, and went ahead and did an iris claw. So this in this sort of situation, I personally felt that this was the safest way in which this eye could be managed. So in summary, not all cases of pseudoexfoliation have a small pupil. You can have widely dilated pupils with all your target sign and everything you can see. Small pupil alone, handled with either stretch pupilloplasty, hooks or rings, whichever is your personal preference. In a shallow AC, hooks are better. Small pupil with phacodonesis, use capsule hooks instead of the iris hooks. And when you have a small pupil, a shallow AC, and a lot of pseudoexfoliation material, the chance for zonule weakness is very high. So always anticipate zonule weakness when you have a lot of this material on the surface of the iris. Thank you very much for your patient hearing, and thank you once again, Dr. Vanashree.
Description and wonderful points that we could gather from there. Sir,
one question. Would you believe that you should do a PI for every iris clip IOL you do?
I do.
But I feel if you have done a good vitrectomy, I have not had any pupillary block, but yes, if the vitreous is not well removed, and then...
So there are two categories. One is the iris claws, which you do late as a secondary procedure, where already vitrectomy, everything has to be done. Suppose the nucleus goes down, you get a refer case or somewhere. Those things you can do without. But on the table,
So we'll move to the next talk. Let me invite Dr. Meenu Mathan sir. He's a senior eminent surgeon from Chaitanya Institute, Trivandrum, and he'll be talking to us about small pupils in complicated cataracts. How do you go about managing those?
As I was telling, one full session on small pupils. And as we were used to pass off small pupils as 15 minutes talk. In the last AUs, we had one session on if the nucleus doesn't crack, what do you do? One full 1.5 hours. So we are coming into very focused topics. No financial interest in this. I don't want to talk about the theory of uveitis and how you get small pupil and all those, how do you treat, because I have a uveitis expert in my hospital. Whoever comes with uvea will go there. They will give clearance, they will give a cover and then ask me to do. So I will show only how it can be done. The rest of the management is there in textbooks, it can be easily read. Anyway, some cases come like this, no pupil. So we will have to search for the pupil in some of these cases. So membranes cover up the pupil, sometimes it will be very pinpoint kind of pupil. But somewhere after you put viscoelastic, you will see that sometimes visco goes underneath through some opening, or somewhere you will see a clearing. So identify that area by touching on the edges of the one and then cut it with the when he was telling that micro scissor, forceps is required, micro scissor is also required. So a pair of micro scissor and micro forceps are the requirements now for most of these complicated surgeries. So once you remove that like this, then we can manage the pupil which is now formed. Okay, one choice is to do the stretch pupilloplasty. Only thing is, if you go through two paracentesis, well and good. If you go through main incision, it may leak. So put sodium hyaluronate and engage the second Coughlin hook later, so that you don't have to manipulate too much in trying to find out where is the edge and touch. Some Indian companies make Coughlin hook with no gap at all. It is just like a thin paper can go inside. So try to identify under microscope what Coughlin hook or why hook you are buying, and it should at least engage an iris. So such instruments please buy. Some instruments come without any gap also. So uveitic pupil, good thing is that if you stretch, it will expand. But remember, if you are going to do phaco, this margin is always floppy. After you stretch and break it, it's always floppy. And as he said, it was very thin and fluttery, and it always comes into your phaco probe, even if you don't want it to come into your phaco probe. So beware of these kind of stretched fibrotic pupils which you have stretched and made more loose and lax. So this is another typical black cataract which I was showing. First itself decided to do SACs. So sometimes you become, there is no point in trying to do phaco. So here again it stretches so nicely, and SACs is good. Before this one also you can do an SACs. You can do a canopodon underneath the pupil and also. Now I have stopped all those. So as she was telling, visualization is very important. So you visualize and do everything. No, nothing under iris and all. All hooks, everything are available. Please expand.
Can you see the video stop?
People will get surprised and suddenly video will come. That's their technology like that from Trivandrum. And so it is actually very small, and they need not be hydrated. They are not multiple paracentesis. They do not induce astigmatism. Please let go of all these myths that if you put incisions for hooks, it will induce astigmatism, it will be more openings and all those. These are very, very minute openings. Only thing is, you should not be going into the cornea and making it. It should be parallel to the iris and the stab entry, and the smallest possible. Try to see what is the smallest possible for the hooks which you have. So don't buy this thick blue ones which some companies, I don't have anything against companies, but that are very thick ones need very large openings. So here again you see fibrosis. This is the point which we have to identify. Identify where the fibrotic margin is there and make a small nick. Don't cut the sphincter, but if you make a small nick there, it will be easy to drag it along, and don't pull it drastically towards you, because it can cause a root iridiolysis from the iris root. So, not radially, tangentially pull and try to tease out this. Once these membranes are gone, the pupil becomes much loose and it becomes much free. Then it is more amenable to stretch or even hooking and all those things. Otherwise, it will tear more and it will look very bad post-operatively. So the more number of hooks you put, the lesser it will tear. And so 4 if you put and 1 if you put sub-incisional, as was being told during last course. Subincisional takes care of the iris prolapse and the iris damage and all those things. And the lesser number, more number, the lesser tears which you get on the pupillary margin, and you don't have to pull it towards the equator or the angle. It needs to be a 5.5. That's all. 5.5, 5 millimeter Rex is more than enough. So don't pull back. See, some cases you see like this. It will look all fine, but then there are membranes which are covering this kind of mature cataract. So if you identify the gap area at the pupillary margin and then retract these membranes, then only you can approach the nucleus or the capsule. Otherwise you cannot approach. So try to identify, see I am trying to get a separation, and now you can separate. Then use forceps and separate, and then continue with the surgery, because here you can stain after putting the hooks. Don't put HPMC and then try to stain. If you want to stain after putting visco, put sodium hyaluronate and put little bit of saline on top of the capsule, and then put drop by drop blue, and then paint. Move the cannula over the capsule so that it can paint. Or release off take out all the visco which you have put with the Simco or IA or whatever, and then put air and put blue. So this is the uvatic one, classical one, which ideally has to be separated. You identify, sometimes the attachment will not be there just on the pupillary margin. It will be there broad based, iris will be fully stuck. So push visco all along so that it goes underneath the iris and releases the whole thing. And then give it a small stretch, because these are very rigid ones. So I have stopped using malucentry, very costly. That is it. So make in India. I have no financial interest in this. So I use nowadays only this. I have become a big fan of it. Very easy to introduce this, and it looks very small, but it is not small. 5.5 is more than enough to do an adequate rexus and do any phaco. For any hard cataract, I am using this one only. And you need to use forceps, not this kind of forceps initially at least. The forceps which is being supplied by the manufacturer is also there. Or you can use this encrypting one which is blunt tipped, not the sharp tipped, and that can damage the capsule. So 2 paracentesis on either sides, and sometimes the third one, last one, you can hold with the forceps and go underneath with the googlets and pull back the iris and tuck it onto this one. Rather than pushing the ring far away, you can just go pull the iris back and then put it onto this one. So now see, this is a rigid one, that's why it is not expanded so very well, but still this is more than enough to do a clean phaco. See, 5.5, sure that it will not constrict is more than enough. 5.5 you start with and think it will constrict at any point of time. That is the one which is more dicey and difficult to do. This will stay on till there. Only thing in IFIS, I think there is a talk on IFIS. IFIS will have a problem with this, that they will talk to you. But then here, it holds on very well. And after taking it out, it generally does not damage sphincter as much as iris hooks if you stretch too much. But this also breaks the sphincter, and there will be some irregularity. One can be taken out, and the rest will follow. It can come through the paracentesis and easily it comes out. So not very bad, and it doesn't tear that bad. That is just because it is not stretched too much like your iris hooks. So just the last one on SICS. With hooks you can do SICS also. Visibility is the key. So to do a good rexus in a large rexus in a mature cataract, please do open up the iris, stain, and do a good rexus. Good means big rexus, adequate for the nucleus. This one does not have a very large nucleus, but still you need at least a 6.5 for this kind of a mature cataract. So once you do this, there are different ways. Release only one subincisional or release all 3. Just retain one. After one pole is out, and because there will be crowding of the iris if you have all the hooks on. And after that you can prolapse it out and then take it out and then put the hooks back on and then aspirate the cortex from the back. Now the system is being dialed out and you take out the hooks back in and finish. Thank you very much.
Find that little gap, and that's where you start off. I think that was a very wonderful point, sir. Any questions in the audience?
Yeah, just one question. Dr. Vipul, supposing you are staining the capsule, pupil is small, you have stained the capsule and then you use the iris hook. Have you felt the need to go back and stain again, because the peripheral part of the anterior capsule is not stained, only the center is stained?
The point is, we don't want stain in the center. Point is, why should we stain one for the central 4 millimeters? You need not.
No,
because you are going to do a 5 millimeter.
Initially you have not thought of doing the thing.
Any small pupil, I do not stain without stretching. sometimes you inject underneath, it goes through the zonules, it goes through the PC, behind the PC. So there is no point in, I do not personally stain without stretching the pupil, and we need a stain at the mid-periphery, at around 5.5 area. So stain in the periphery and so put air or put sodium hyaluronic.
With intraoperative floppy iris syndrome. So it's a intraoperative floppy iris syndrome is characterized by billowing of a floppy iris, propensity for iris prolapse through surgical incisions, and progressive intraoperative meiosis during phacoemulsification. So the overall prevalence is around 1 to 12%, and it was originally described with tamsulosin, but there are several other risk factors like increasing age, hypertension, finasteride, AC inhibitors, and antihypertensive drugs. And the risk is more if the dilated pupillary diameter is less than 7 and the dilated pupil to limbal ratio is less than 0.6. So stopping tamsulosin does not prevent its occurrence. Now let's see what happens in IFIS. See this patient, you can see during phacoemulsification, the iris is floppy and the pupillary margin was coming to the phaco probe, and you can see the fluttering and floppiness of the iris because of the fluidics, and the iris was coming out through all the incisions, thigh ports and the clear corneal incisions. Now this patient was not on tamsulosin, so I didn't suspect iris. So phaco was done, and then during phaco there was progressive meiosis, and as you can see here, when sculpting, when the fluid was going under the iris got lifted up and there was fluttering and floppiness. And during this the pupil further came down, and then somehow I took out these nuclear pieces through the small pupil, and it's luckily the nucleus was not very hard, and so I could take out the nucleus, and in this case I coated the endothelium with viscose, so that because I was doing an antechamber phaco to protect the endothelium, and somehow there was no complications, and I could place a lens inside the bag. Now, so having seen this, how can we prevent these complications? So one is we should have a proper preoperative and surgical planning. So preoperatively I give atropine drops twice daily, 2 days prior to surgery. And preoperative and end-stage drops can reduce the incidence of intraoperative meiosis. And you should have dispersive OVDs, iris hooks and rings in case you need them. And before surgery I inject intracameral adrenaline. Now this patient was on tamsulosin. So after injecting dispersive OVD into the anterior chamber, so one thing is that you should take care not to pressurize the anterior chamber, don't overinflate the chamber, because the iris keeps coming out then. And then after putting dispersive OVD, that is, take care not to overinflate the chamber, the rhexis was done. This is NS3 plus cataract. You should have an adequate size rhexis. And then during hydrodissection, you can see that there's a tendency for the iris to prolapse through the clear corneal incision there. So and you can see the floppiness, and then the nucleus was nudged to take out the trapped fluid behind the nucleus, and the mobility was ensured. And see, as now I am proceeding with phaco with normal parameters. The bottle height is usual, the aspiration flow rate is usual. So see, you can see the fluttering and floppiness of iris. Now what I did is I reduced the phaco parameters, that is aspiration flow and the bottle height. See, now the chamber became stable and the iris stopped fluttering and coming to the probe. So one important thing is you should operate at the low phaco parameters, that is low IOP if it is active fluidics, or low bottle height and low aspiration flow rate. Then another thing is, when you are doing phaco, here you are doing in the slightly in the anterior plane, that is it should be in the supracapsular plane, and you should chop the nucleus into multiple small pieces so that it will be easy to emulsify, and carry emulsification in a slightly anterior plane, that is in the supracapsular plane. And during cortex removal also, you should take care to reduce the parameters, that is low aspiration flow, so that everything within the anterior chamber happens very slowly, so that the anterior chamber becomes stable and the iris also becomes stable. Now after phaco, a 3-piece foldable IOL is going inside the anterior chamber. I usually put them on the iris and then dilate into the anterior chamber. Now coming here, this patient was on tamsulosin. So I was expecting IFIS because the pupil was not dilating well. So I have decided to use Malugan ring in this case. So intracameral adrenaline was injected, but there was not much dilatation of the pupil. So then dispersive OVD is going in, and then I don't overinflate the chamber, and the side port should have a long intracorneal tunnel, and here the clear cornea incision is also having a long intracorneal tunnel so that it prevents the iris prolapse. Now I inject little gel under the iris so that I can place the ring easily, so it gets lifted up from the anterior capsule. So by injecting, you can see the two scrolls that is getting engaged initially, but the other two scrolls are not getting engaged. So I've placed them manually. Those are engaged against the iris border. The anterior chamber should not be shallow when you are using these rings. So it should be deep, at least normal. And then dissection should be very gentle. Don't keep on injecting fluid because it is that time that iris start creating problem. And then nucleus is emulsified. A routine phaco is done, and place a single piece hydrophobic acrylic lens inside the bag. Now after that, I am slowly releasing the scrolls, and the hook was carefully placed on the iris, and little gel was injected, and it was taken out. Now at the end of this surgery, the pupil has come down almost back to the physiological position, here as you can see. Now this is the second case. Actually this patient had severe iris in the other eye, and the pupil was had moderate dilatation, but since he had severe iris in the other eye, I decided to use Mahesh ring in the beginning itself, and the nucleus is very hard. It's around NS4, and here as you can see, the ring is giving a good adequate dilatation. And then the rexus is slightly larger because the cataract was little on the harder side. And you can see even after putting the hooks, the iris between the scrolls, that is coming to the probe and it is showing the floppiness. So then there was iris prolapse of the main tunnel, so the scroll came out. Then again I replaced it and completed phaco. As sir told, I had put trypan blue in the beginning, that's why it has gone behind and a little bluish tint is coming from the vitreous. And finally the iris hook was taken out mechanically, and the case was completed. Now in this case, I've used iris hooks. As sir told, you have to make the incision for putting iris hooks just inside the limbus, and it should not have a long tunnel, it should be very short, and fill the chamber with viscoelastic. It is difficult to place the first hook. Once you lift up the iris from the capsule, placing rest of the hooks are very easy. And the only thing is you have to retract the sleeve adequately before hooking the iris, and then adjust the tension so that you get enough dilatation and don't tighten it too much. And then rest of the things was done in the normal way. Phacoemulsification is carried out, again using low parameters. And here I am placing the lens over the iris, and then I am dialing it into the back. Now while taking out the hook, you have to retract the sleeve and see the hook should be parallel to the iris while you are taking out and the paracentesis, so that while taking out you don't damage your paracentesis and the iris margin. And actually after putting there were few sphincter tears because I have tightened it too much, and it's not that physiological as in the case of Mahesh. Now coming to the practical tips, few things. One is preoperative atropine and NSAID drops are useful in reducing the incidence of intraoperative miosis. And the side ports should have very small and should have a long intracorneal tunnel. And you should have a perfect phaco wound with the long clear corneal tunnels. And you should use dispersive OVD because the iris will behave better with that in the case of IFIS. And never overinflate the chamber because it is that time the iris starts coming out. And hydrodissection should be gentle with as little fluid as possible. And phaco should be done with low pressure, low aspiration flow parameters. And you can have a slightly anterior plane emulsification so that the fluid current doesn't go under the iris and lifts up and causes prolapse. And you should always use pupil expansion devices whenever it is needed. Thank you.
Routine phacoemulsifications and going towards more complex cases. Many times we have a mental block that can I really use this device? Can I go? How do I manage it? How do I handle it? Or which one should I use? So my idea was to talk about that. So as previously discussed, we all know that small pupils are basically of two types. One is the floppy one which comes with IFIS, and the other is the rigid pupil which may be because of diabetes or long-term use of anesthetic combinations, phenylephrine 0.1% with lignocaine and tropicamide, or you can use epinephrine with oculan. That will help us to dilate the pupil intraocular. Or another thing is we can use the mydriatic agent in the irrigation fluid to maintain the dilatation during the surgery. Now if nothing of this helps, then during surgery what we try first is we try the viscoelastic, that is viscomydriasis. We push in a good amount of viscoat or orocoat and try and dilate the pupil. When that doesn't work, we go to the other devices. And of course, right from the olden times, we have the mechanical stretching or sphincterotomy using the Y hooks. So what are these hooks and rings and what are we talking about? So basically iris retractors, the previous speakers have mentioned, but I would like to give some finer points about these. So basically these are 50 polypropylene flexible hooks. So looking at the hook, first we feel, oh, how do we use it? Oh, what will happen? Will I really go in and damage the iris? What would happen? So the important tip is that fill the anterior chamber well with a viscoelastic, and the paracentesis have to be really small. Now I'll discuss it when I show you the video. The advantage with the hooks is that it is affordable, 500 rupees, and you get a set of 5 hooks. And usually they are readily available in all the OT setups. The downside is that you need more incisions, it is slightly time consuming, and if there are other things like pterygium or bleb or keratotomy patients, then creating multiple openings may become an issue. And if the eye is very small, you have less space. So when you have these iris hooks, you have less space to manipulate your other instruments. Coming to the rings, there are various rings available. The most commonly used worldwide is the Maligan ring. We have our Indian innovation, that is by Dr. Bhattacharjee, that is a BHEX ring. And there are other pupil expanders used worldwide, which are not that very popular. Now, Maligan ring is slightly on the expensive side, but the advantage is that you do not need extra incisions. You can go through the main 2.2 or 2.4 incision, and it is basically a 40 or 50 polypropylene device which is square shaped, which has 4 scrolls, and it engages the pupil at 8 points, giving you a circular opening. Again, it comes in 2 forms. It can be either 6.25 mm opening or 7 mm opening. Now, what was the advantage with Malignant 2.0 was that being a thinner ring, it is less bulky, and the increased scroll depth will help to engage the pupillary margin more easily. BHEX is a hexagonal device, which is a plastic device actually. It gives 5.5 mm pupillary dilatation, and you need a 23 gauge micro forceps to actually place it in, and also you can use thin Sinskey's hooks to place the scrolls. Coming to the video, now this, if you see, it's a mid-dilating pupil, and with phenylephrine, it is giving a fairly good dilatation of around 6 millimeters. And now when you go in with dispersive viscoelastic like Viscoat, you get a fairly good dilatation with a good view. Now when that is not happening, you go to hooks. So again in hooks, very small paracentesis, 1 millimeters, you can use the MBR or even the 15 mm blade, but ensure that it is parallel at the posterior limbus and parallel to the iris plane, so that you don't have a tenting of the iris hooks. To McPherson's forceps, be very gentle and careful. First, I prefer to just place all the hooks, just engage the pupillary margin. The silicone stoppers actually give a guide to the direction of how your iris hook is, and that will give us a fairly good idea. And once all the hooks are placed, that is the time when you go and stretch the hooks, only giving you an opening of around 5.5 millimeters. I prefer the hexagonal opening, but some people prefer 4 hooks giving a diamond shape opening, but I don't stretch it right up to the periphery. And my phaco probe is usually not having a hook below it. I do not find it the iris has never come prolapsed to the main one in my case. Now coming to the rings, now this was a patient which required a toric IOL, and it was a floppy iris. After I stained, you can see that the iris has started coming to the side port. So I knew that this is going to be a very floppy iris. Don't be fooled by the viscoelastic being injected and slight dilatation that you get, because it is going to come down again later. So here I wanted to use the Maligan ring. Now the important thing here is that you try and engage 2 scrolls, but sometimes it may not be possible. And with your other hand, keep a Kruglan's hook in place, and you can easily, in various directions, go and engage the scrolls into the pupillary margin. Now, after the phacoemulsification, when you put the IOL, you can place the, since it was a toric IOL, I wanted to place it along the axis. Remove the viscoelastic from the back, but let some viscoelastic remain in the AC, or if you feel you're washed out too much, go and inject a little bit of viscoelastic, because when you disengage the scrolls, you need the AC to be well formed so that it doesn't go and touch the endothelium. Very gentle mannerism, it easily comes off, and what I find is with malignant ring, actually the damage to the sphincter or pigment dispersion is pretty less in my hands. And then you can take it out with the Kruglan's hook itself, it comes out very easily. And yeah, so the pupil has come down, so we need to ensure that the axis is correct. So you can, under irrigation, just use your Kruglan's hook and visualize the axis well, and then end the case. So Kruglan's hook is a very good device to use when you just need it for some time to visualize what is happening underneath that small pupil. And another device, that is your B-hex. Actually, can I move it slightly? Can you give me the cursor? Oh. No, the next video. Yeah. For the B-hex, actually, it is very flexible, but it's uniplanar, and I feel that there's a slightly more learning curve to the B-hex. It is very floppy, and I don't prefer it for floppy iris. I mean, if you have a rigid pupil, yes, B-hex works better, but for floppy iris or IFIS cases, I feel the malignant ring does better. And just going to the next thing, the take-home message I would like to say is, good visualization again is essential for safe surgery. Use what is available and what you are comfortable with. Avoid trauma to the sphincter and the iris root, because you may be enthusiastic and you may pull, so that will cause damage and iridodialysis. And post-operatively, you may need to manage the inflammation and cystoid macular edema, which is seen slightly more in these cases, which may require devices to be used. Thank you. Thanks a lot.
Thank you, Doctor. Because
on the rhexis, so that the rhexis occurs even before the fluid comes out, this intumescent cataract. But here you could just phacoaspirate or just use an IA, it's a very soft cataract. And needless to say, polishing of the anterior posterior chamber is mandated in these kind of cases. And then you inject your lens and you bail yourself out. Now this is a significantly hard white cataract, and it looks as if the rhexis is quite fibrous. Sometimes in very dense fibrosis, a femtolaser passage is not very comfortable, but this fibrosis was not that intense. The only thing, you cannot just bunch it up and lift it, it's not free floating, so you need to use a cystitome to remove it. But as I'm just trying to inject viscoelastic, I see that small tag which is there, which it is important to remove it, make it an entirely smooth rhexis, because these could become the weak points for a rhexis extension. Then it is about, of course, in these total cataracts, there is no nuclear fragmentation which happens because it's a totally white opaque cataract, and you have to do your manual approach, and then it just becomes a routine surgery. But getting a consistent rhexis in all of these difficult cases is what which makes a phacoemulsification a consistent and a repeatable success, which may not really happen in if you are on a manual mode. Now this was a case which started off, which was a fairly normal dilating pupil, but it did look, it was a little smaller in size. You have the ability, when the pupil does not accept it, you could go on to the pupil maximized button, you can press that, which will give you the maximal pupil size, but you can cheat the machine and use your cursors to enlarge the rhexis so that it comes within 100 micron of the iris margin, because it will not impact the iris or cause miosis because of the prostaglandin release if it is that 100 micron space is there. And then with that, the decent 5mm rhexis could be worked out. And then you have to just bunch up the rhexis, because you need to be sure that there are no tissue adhesions and you have got a complete rhexis. In a small eye and a shallow eye, you need to do very gentle hydro and ensure you keep decompressing and then rotate the nucleus. After clearing the little superficial epinucleus and cortex, make a small trench and use that as a fulcrum to split it into two halves. And then what these are cases which you would have to have used an iris hoop or anything more complex, as was all discussed in the whole session. But as you can see here with the femtocataract platform, although the pupil size is coming down, the challenging movements of a rhexis or softening or segmentation of the nucleus is also completely done, that you are able to actually treat these cases as a routine normal case, and you are able to get done with it. Of course, you need to be ensure that you remove the viscoelastic in front and behind the IOL, do all those important things, retract the iris to ensure that you have removed all the cortex. Those steps are there. Now this is a polar cataract. Here multiple cylinders are being created. This is on a different laser platform. Multiple cylinders are created, and you could ensure that there is energy could be lowered if you want to have less of cavitation bubbles. And the advantage of having multiple cylinders is it would create multiple epinuclear cushions along the way, so that the surgery done anteriorly will have no impact on the weak posterior capsule. It was a free floating rhexis which comes on, gentle hydrodelineation is done and decompression of the bag. So now all that is going to be done is separating these pies which have been created by the segmentation, and just chew it up with a phaco so that one level of the tire is eaten up, and keep going layer by layer. But all along your posterior capsule is not impacted by any of the intracapsular pressure changes which are occurring with the phacoemulsification. As you can see, the parameters are also kept at a fairly low level. And finally, all that you have is just one epinucleus cushion, and that also very easily gets folded up, and you find that a polar cataract is not at all a challenging case if you are able to do it on a femtocataract platform, unless an ASOCT has told you there's a PC dehiscence, which of course then it brings in its own quota of challenges in a case. And then here, this was a coaxial IA, so we have used aspiration port to get the sub-incisional cortex, because you don't want at any point of time anterior chamber shallow, even that can trigger off PCR at the most unexpected moment. So this was a case which happened well. Now this is again another case which is actually a small pupil and a dense, a thick nucleus which is there. Which again is something which I'm going back to explain it to you. I did the pupil maximized, but still the pupil size was only 4.5. So then I've used manual cursors. But one thing which I did miss out was that there was a through and through opening which occurred when doing the astigmatic keratotomy, which was evident during laser delivery. But when I started the surgery, I could see that the fluid was coming out through this perforated wound. It absolutely mandates, it's a very rarest of rare complications, that you need to suture up that small perforated linear incision, because otherwise with a small pupil and a fluid egress, it would actually become nearly impossible to do an easy surgery. But again, because of the femto dissection and the fragmentation, even that amount of smallness of pupil and fluid keeping coming out of the perforated wound, we still could complete it as a normal, near routine normal case, and thankfully it did not leave any astigmatic impact. However, a BCL had to be placed. Now this was a case where there was an ICL in the patient's eye altogether, so offsets were increased so that it could cut the optical device which was placed on front of the anterior capsule. It was one of those earlier cases where I've increased the vertical spot spacing too, but of late we do not do that. You can see as I'm doing the ICL, there is a cut which has happened on the ICL too by the femto laser pass. So you are left in doubt, and those areas of bubbles which tell us that could be that those areas are uncut areas. So it's better to use your cystitome and tease out the rhexis, which is nearly cut in most parts, and anyway it's a template. Even the areas which are not cut, you can tease it out. You can just go on the flip mode, because invariably these anterior subcapsular cataracts are very soft cataracts, and then the surgery gets done and the IOL is placed. Now this was a case of an intact, so you need to downsize the rhexis a little so that you are able to visualize the rhexis within the intact segment. That is what was done, but even then on the table when starting the surgery, the rhexis was not visible, it was covered by the area of intact, so you needed to gently tease it out. There was always a doubt throughout the case whether there was any area of rhexis extension, because the overlying intacts could have obstructed the in any way the laser pass. I'm not clear on that. and then it is just a question of fragmenting. But every step you need to be careful, because the overlying intacs is sort of obscuring your vision, because you're not able to clearly visualize your excess margin. Even teasing out the cortex has to be done very carefully so that you're on the exact plane, and then the IOL is placed and done. And this was a case of RK, but there were not multiple RK incision, thankfully. But these are all hypertrophic scars, and you could be clear that these areas, the rexus might not get cut completely. That is one challenge which you have. If you have multiple RK incisions, actually it is in mandates that we make your incision more scleral than corneal. But as there were fewer incisions, the incisions were made between the two RK incisions, and you need to remember that these RK incisions could give way at any point of time. You could ensure that the parameters on the phacoemulsification is not very high, there is not too much of pressure in the anterior chamber, enough viscoelastic is placed. But again, incidentally, much to our luck, this was a very soft cataract, and with all the grid softening which happens, it was like just carouseling out of the entire nuclear fragment. But you can see there's a rexus extension, sub-incisionary. Thankfully, the surgery was quite uncomplicated, but that was an area which has given way because of the scar, the hypertrophic scar of the RK, and thus the surgery got done. So I think these are different ways you are able to tweak small parameters and do very well with a femtocataract in some of these moderately challenging cases. Thank you.
Thank you, ma'am.
Those tags, you can see there's a discontinuity in the rexus margin, which you are able to visualize. So it is important to go and make it circumferential in those parts, because these cannot be left alone. These would be areas where there could be a rexus extension. But I don't think there's much of a challenge.